And now I invite to the stage Dr. Damjan Osredkar, who run our Genotype-phenotype Analysis.
Good evening from my side as well, and I would like to thank the previous speakers, Amaya, Shivang, and Nina, for making my task easier, because they have made a great basis for the talk that I'm having now. And I thank the organizers as well to give me the opportunity to present this data, although this data is still preliminary, so I will only be able to share some of the findings that we're still crunching on the data, and as Nina said, we hope to be able to finalize this in the next months and make the data available to the community. So we first started to be interested in CTNNB1 syndrome when we first met Urban, and we learned from him, we learned from the published literature that was available, and we also tried, as Shivanka showed, to make a systematic review of everything that was published and try to learn from all the cases that were described. And what we noted was that there were some clinical features that were very common in the patients, and these were nicely presented by Shivang, and but some of the features were less common. So we kind of realized that there's still a lot that we don't know about the syndrome. And I think the only thing how to answer this question is to go through this in a very systematical manner, which nobody has done before. And that's what we aim to do. So first of all, we realized that maybe there might be, if you don't ask a particular question, you might not get the answer, but it doesn't mean that there's not a problem in the particular field. So what we utilized were systematic approach, which used standardized scales for certain topics, as Nina has neatly presented. And so this is the approach that we took, maybe, as we have seen that patients with CTNNB1 syndrome can vary among themselves in the problems that they have, that there might be some phenotypes out there, so a collection of clinical symptoms that can be grouped in particular groups, and maybe it's possible to predict in which particular group a patient will fall just on the basis of the genetic data that we can get once we diagnose the patient with the CTNNB1 syndrome. So also what is lacking in the field, and this is something that Spila has just mentioned, is basically the next kind of aim is a natural history study. We don't have a very good natural history study on the topic, meaning to look at the symptoms that these patients have over time. So we would know how these patients evolve, which problems are getting worse. Maybe some problems are not getting worse after a certain age, and this is something that would be crucial, especially once you start thinking about the treatment of a disease, because if you know how things normally develop, then once you start treating, you can say whether your patient now being treated is developing better or not better than the previous cohort of patients, or maybe even worse. So this is something that a study that we have performed might give us in the future if we try to collect the data once again after a certain time period. When we talk about the genetics of the CTNNB1 syndrome, there were also some things that weren't really clear. So we knew about the different mutations we had collected. The published cases revealed which mutations are very common and which may be less, but there was no clear picture on which genetic mutations will translate to more or less beta-catenin, and also how this relates to the phenotypes. And as I mentioned, it would be really crucial if we can utilize this genetic data to predict certain phenotypes of the disease, because as you know better than I do, but working in the field of rare diseases, this is a typical question. The parents ask, once you diagnose their child with a rare disease, will our child be able to be independent? Will the child be able to walk? Will the child be able to talk? And quite often you're not capable of giving a really good answer unless you have a strong study behind you that supports certain reasoning. So when we start talking about treatment of the CTNNB1 syndrome, it's also very important to know which problems are more abundant in particular patient. Obviously, you would aim for those that are present in more patients than in those that are very rare. And also it depends on how burdening a certain symptom to a patient. So you again try to aim at those problems that will present a bigger burden for the patient. And this would give you some idea of which problems you have to target. And once you know which clinical problems you need to target, then you might be able to, to go back into anatomy and try to understand which structures in the central nervous system are responsible for a particular behavior, a particular problem, because this is actually quite essential when you decide what technology you're going to use for the treatment of the syndrome, as not all cell types or not all central nervous system structures will be equally treatable by the particular treatment. So this was a little bit a long overview, but I think this is basically the most important slide, because this is something that we are constantly rethinking in the process of trying to get closer to a gene therapy. So Nina has presented how we approach this study, and the data collection has now been closed. We have been able to, I think 124 is the correct number. We got the data from 124 patients. We think it's about a third of all no cases, but of course this...
Testing. Do you hear me?
I hear you. So anyways, we have collected the data from these patients, but the preliminary results of the genotype-phenotype correlations are still kind of, we're working on that. And what I wanted to say also is that the syndrome is very likely, as we have heard several times today, but it's very important, underdiagnosed, because many of these kids and patients are kind of hidden under the umbrella of cerebral palsy. And at our department, for example, we have also did a little study where we have looked into these patients and we did genetic testing in them. We didn't find any additional CTNNB1 patient, but we did find in about 15% of cerebral palsy patients a genetic diagnosis that confirmed, that could explain the problems that the child had. So genetics is becoming more readily available and also a very crucial tool in dealing with patients with rare diseases. So we have gathered the detailed genetic data, and Professor Chan, whom probably he was talking to, will present the sub-study on some of the that was performed with the data that we provided for 56 patients. So he used the genetic data on these patients and did cell constructs that then he tested for the beta-catenin protein expression, and this is something that we also will use in our analysis to try to predict the phenotypes. Okay, so this has been told. So the statistics, this can, we have a lot of data, but when it comes to statistics, there's always too little data. So we tried different approaches to best describe our cohorts and to get as much data as we can from the answers that we got from the patients. So we used some basic descriptives for the phenotype characteristics, but then we also used more sophisticated methods, and I thank David Gosar for his work so far in this field. So we used factor analysis and multiple imputation to see whether we can identify certain components or dimensions that could be used to effectively describe a particular CTNNB1 phenotype. And I will walk you briefly through what we have found so far. And we have also used Bayesian regression, another statistical method with which we try then compare, so first, the type of genetic mutation, and then which part of the protein CTNNB1 is being affected, and also the level of the supposed level of catenin expression to predict those phenotypes. So just briefly, we have found that the frameshift mutation was the most abundant mutation in this cohort of patients, and this is actually different than the systematic review that was showed before, where I think the nonsense mutations were the most common ones. So it is important to go, into a study of a particular syndrome in a very, very systematic manner, because I'm not saying that this is actually the cause of this difference, but just because you have to have as much data as possible, and collecting data for 124 patients is more than what the cohorts that were previously described, and so you can find changes in here. So as you can see, nonsense mutations were the next most common mutation, missense mutations even less so, and so forth. We have also found that there were some exons that were hot spots for mutations. So exons 4, 7, 9, and 11 were the most commonly affected in our cohort of patients. When we looked at which parts of the protein has been targeted with these mutations, and this was only done in a subset of our patients, their medullary repeats were most commonly targeted areas of the protein, and so probably malfunctioning, whereas the N-terminal domain was the next most common in 60%, C-terminal in 3.6%, and the helix was only affected in less than 2%. So this is the data that Professor Chan will probably, this is his data, and he will talk more about, but I'm just trying to show that we took the mutations from 56 patients, aligned them on the gene, CTNNB1 gene, and then using the constructs, he was able to see how much beta-catenin was produced by this cell construct compared to the wild-type cells, so meaning normal cells. And as you can see, in most of these cell constructs, the beta-catenin level were lower than what we found, what is found in healthy cells. This was again shown by Nina, but what I just wanted to highlight here is that, as we expected, not all problems are equally abundant in the patient. So not every patient has, the most severe level of a particular scale. As you can see, for example, the speech and language problems are quite commonly in the more severe side of the spectrum, for example, whereas the feeding is not so commonly affected. And these are all, this has many dimensions. This little table has many dimensions, and we are using all this data to then feed the statistical model to give us the results that I'm showing you now. So, as I said, we were using a statistical method to try to predict different components. So one component would mean we could present a certain phenotype, and for example, with 4 of the, you can see the scree plot, it's the so-called scree plot, which tries to describe the variability in our patients. You can see that the first 4 components, the first 4 bars, would describe most of the variability in our cohort of patients. So these are the 4 components that we use for the statistical analysis, and I'm only going to show you an approximate of one of the first 2 components, and to try to feel what the difference between one or the other component would be. So for example, patients that would refer to the first component would have a better adaptive behavior, they would less commonly have autism, they were more likely to be able to walk independently or with support, they less likely had dystonia, and they less likely had seizures or showed signs of developmental regression. But for example, patients that would be more related to the second component would again have better adaptive behavior and less autism. But for example, in this case, in the second component patients, they would have greater motor impairment and motor regression. So I'm just briefly showing you now the genotype correlation with the phenotypes, and as this data, as I said several times now, is not yet finalized. We have looked into the type of mutation. So we compared missense mutations, which supposedly have the smallest impact on the phenotype, and compared these individuals with the nonsense, frameshift, and splice mutations. And we have found that, for example, comparison in the type of mutation would reflect in the first phenotype component. So the patients which would have nonsense, frameshift, or a splice mutation would usually have lower adaptive skills, were more likely to show signs of significant motor impairment, were more likely to have seizures, which more likely show signs of developmental regression, and would also more likely show symptoms of autism spectrum disorder. And if we looked at which part of the protein is affected, We compared this. We took the Armadillo domain as the reference group, and then if the mutation had the N-terminal mutation, these patients would normally they would be mostly best differentiated looking at the second component of this analysis, meaning that these patients, so those patients who would have an N-terminal mutation would have symptoms of psychopathology, including autism spectrum disorder, and they would less likely show motor impairment. Whereas mutations that would have a helix C domain affected, they would have less psychopathological symptoms, they would have poorer motor functioning, a greater prevalence of visual system involvement, and the presence of specific dysmorphic features. So to conclude, we were able to analyze the data in a very systematic way using standardized scales, which we think is a valid way to approach these patients, not just for this particular project, but also for any future projects. And we have been able to identify certain phenotypes that we can use for the statistical comparisons and when we try to predict how our patients are going to behave over time or which symptoms they will have. So we have found associations in the type of mutation, the protein structure affected, but also in the beta-catenin level expression, which was as predicted in the cell models. And this study has the potential for a natural history study if continued. So I would thank the patients and the parents for their help and for all the time they have spent with Nina asking them 500 questions. It is a lot of work, I can tell you, and from both sides, I guess. So thanks again. And I also think that, and I'm thankful really for this meeting, because I think without collaboration, this field could not move forward. I feel really relieved seeing so many, scientists, but also other, associations helping in the process, not just trying to develop, a therapy, but also helping in so many other ways which are relevant for the patient. So I think, working together, bringing the data together and collaborating is really the way forward. So I thank you all for your attention, and I would particularly like to thank the team that I work with very closely, and for this particular study, Nina and David had done a lot of work, and of course Spila for coordinating all the communications with the parents. So thank you.